Yeah, coordinators.
Yes.
You just tell me when I'm live so I can start.
Done, sir. Start कर सकते हैं हम.
Okay. Good evening, everybody. And today we have the day 2 of this JST 16th Masterclass series, which is virtually getting transmitted. And at the outset, I would like to thank Professor Deeksha Kapoor for giving us an opportunity to share some of our experience, the experience of the learned speakers who are a part of this program. And I take also this opportunity to thank all the participants, yesterday's participants and today's participants, Dr. Sadaf Ali from SKIMS Srinagar, Dr. Kalayarasan from JIPMER Pondicherry, Dr. Deeksha Kapoor from BLK Max New Delhi, and Dr. Anushri Loyal from Mahatma Gandhi Medical College and Hospital, Jaipur. We'll also be having some panelists, Dr. H. Ramesh and Dr. Rao, who are likely to join during the open house session. So due to some technical issues, Dr. Sadaf might get delayed in joining. So let me just check whether she has joined. And Dr. Sadaf, are you available? Dr. Sadaf, can you hear me?
Hi, good evening, sir.
Yeah, good
I
evening. Are you ready to share your slides and start?
No, this is my iPhone. I'm not able to join in through my laptop, so it will take me some time. Can we start
Yeah,
with some
so
another?
yeah. That's what we have decided. So we will start with Dr. Kalayarasan,
Yeah.
who's additional professor in the Department of Surgical Gastroenterology at JIPMER Pondicherry, and we will continue with the talk on minimal access surgery, which we started yesterday, and we had an overview yesterday presentation, and today we'll have a little bit of specifics on that. That is laparoscopy assisted and robotic assisted distal gastrectomy for carcinoma stomach. So over to you, Dr. Kalayarasan.
Yeah, thank you, sir. Thank you for the kind introduction. So, I think my slides are visible. Oh. So I'll give a overview of the laparoscopic and robotic assisted distal gastrectomy for gastric cancer. So we had this literature review on the minimally invasive techniques yesterday. So I won't be focusing too much on the literature on robotic versus laparoscopy, except for two key studies. In fact, this is the first randomized trial comparing robotic versus laparoscopic distal gastrectomy from China. This is from Fujian, which is one of the very high volume center for gastric cancer. Now, if you see the evidence, the robotic approach is helpful in certain lymph node stations. So we had a excellent lecture on the various lymph node stations. And if you see here, the number 1 to 6, which are the perigastric lymph nodes, there's not much difference between a robotic versus laparoscopic. But however, if you go to the stations 7 to 12, so this is precisely for the distal gastrectomy. So which means we are not going to talk about the stations 11D or the station 2. So from station 7, 8A, 9, 11P, and 2A, so as the lymph node stations go beyond the perigastric region, then the robotic approach helps in achieving more complete lymphadenectomy. In other words, the compliance of lymphadenectomy improves for the extra perigastric lymph node stations. So that's an important message from this publication. And the second advantage which was highlighted is the initiation of adjuvant chemotherapy. In this study, the difference was statistically significant. However, if you see, it was 4 days between the robotic and laparoscopy. So clinically, how much it's going to make impact on the outcome is doubtful. But however, this is the what reported in that study. Now, the same authors came out with their long-term outcome results this year. Again, this was highlighted yesterday by Dr. Vani, and what they have reported is the 3-year disease-free survival and the overall survival were better in robotic arm. And the reasons attributed were what they have reported in their first publication, that's the short-term outcomes, where the compliance of lymphadenectomy was better, the complications was lesser with respect to the blood loss, and also the early initiation of adjuvant chemotherapy. Now, if you see, so that was the randomized trial evidence. And if you see the systematic review, which was published this year, in which they have included almost 68,000, more than 68,000 patients. And what was reported is robotic gastrectomy, the lymph node harvest was higher, the intraoperative blood loss was less, hospital stay was shorter, and the conversion was lower, and the overall post-op complications was also less. However, the operative time was more in robotic surgery, and obviously the cost in the current era is higher in the robotic arm. Now, this is the evidence, so I'm not going too much into it. So the initial evidence was not too much in favor of robotic. If you see actually the articles published in late 2018, 2019, so the differences was not really significant, and we didn't have much evidence to support robotic surgery. But the recent publications have shown the benefits. Personally, we do both robotic and laparoscopic. And since we don't use the advanced energy devices in robotic, that is the harmonic and the vessel sealer, we don't use in our setting. So in our experience also, the robotic was associated with the prolonged operative time. And probably that was one of the reasons where the earlier publications were showing prolonged operative times. But recently, many centers have started using the robotic harmonic or the robotic vessel sealer. And that's why the differences is not much. Now, if you see the technical aspect regarding the port position, for robotic, if we are not going to use the harmonic, the robotic harmonic, and we are going to use a vessel sealer, then all the robotic ports are placed at the level of the umbilicus. So either above or below, depending upon the distance from the zippy. And then one assistant trocar is placed at the below the level of umbilicus. And we usually use this arm, one on the left side of the umbilicus for the camera. But depending upon the patient anatomy, this can be moved here also. So primarily when we use scissors and the bipolar forceps. But in case, if you want to use the robotic harmonic, then the trocar position has to be modified. These two lateral trocars have to be above, because we all know the robotic harmonic is the only instrument which is non-articulating. And so we need to have our trocar position in line with the angle in which the harmonic has to be used. Since when we do the station 6 and 5, so the harmonic will be coming from this arm. And when we use the harmonic for the other stations, that is station 7, 9, the harmonic will be coming from here. So that's why we place this higher up. So this is an important thing you need to remember when you are placing the ports, trocars for robotic gastrectomy, depending upon what type of energy device you are going to use. On the other hand, if you are going to do a laparoscopic approach, so this is the standard trocar position. We place the infraumbilical, that is for the camera. And then we do the lymph node station 5 and 6 from using these two trocars with the surgeon standing on the left side of the patient. And for the remaining lymph node dissection and also for reconstruction, the surgeons shift to the right side. So we use these two trocars as the working trocar. So that's approach what we follow. Obviously, there are various techniques of doing a laparoscopic gastrectomy. And the order of lymphadenectomy which we follow is starting with the infrapyloric, then the suprapancreatic, stations 5, 12A, and then we do the 7, 8A, 9, 11P, and finally the upper perigastric. So we had a good discussion on the lymph node anatomy. Today, what I'll focus is on a technique of doing those dissection. Now, we start with station 6, that's infrapyloric. And it's basically the lymph nodes along the origin of the right gastroepiploid till its first branch. And so it has 3 components. One is the artery. The artery again further divided those along the right gastroepiploid and those along the infrapyloric, and the vein till its confluence of the right gastroepiploid vein with the anterior superior pancreatiodontal vein. Now, for doing the station 6 lymph nodes, we need to enter in the right plane. So we all know as we come close to the right gastroepiploid vessels, so we have this fusion fascia, the gastrocolic fusion fascia, that is the 2 posteriors, the greater momentum and the transverse mesocolon, they fuse. So we need to enter in the right plane so that the mesocolon and the mesocolic vessels, they are separated from the gastric vessels. Now, this is the anatomy which you should be familiar in this region. So we have the right gastroepiploic vein, which is joined by the anterosuperior pancreatiodontal vein. And then you will have this right colic vein, and you'll also have some infrapyloric veins. So they all join together and form the gastrocolic trunk. And for station 6, we will be dividing the right gastroepiploic vein at its junction with the ASPDV and the gastrocolic trunk. So we don't have to go below this. We have to, so because below this will be 14B, which is not routinely required as part of standard D2 gastrectomy. So I'll show a brief video of the station 6, especially the going in the right plane. So you can see here, this is the gastrocolic fusion fascia. Now, all these vessels, they belong to the colon. And here you will have the pancreatiodontal vein and the gastroepiploid vein. So when you go in this proper fusion fascia, you can see here the colic veins, they are getting separated from the gastroepiploid and the pancreaticoduodenal vein. So this is a separation, and we can make out the colic veins getting separated from the gastrocolic. So you will have the accessory right colic vein here, which we will divide. So this will be divided, and this is the gastroepiploid vein, and this is the pancreaticoduodenal vein, and this is the junction in which we will be dividing the gastroepiploid vein. So this is the area of the dissection along the gastroepiploid vein. Then we have the gastroepiploid artery and then the infrapyloric artery. So what the point to remember is the infrapyloric artery either can originate separately from the gastroduodenal, or it can be a branch from the right gastroepiploid. So in this scenario, you will have to ligate only one vessel, but in this scenario, you will end up ligating two vessels for the station 6 lymph node dissection. Another important point to remember while doing this station 6 is because the gastroduodenal artery divides into the right gastroepiploic and the antero-superior pancreaticoduodenal artery. If we are not careful, for example, if you are going to ligate at this point, then we will inadvertently injure this antero-superior pancreaticoduodenal artery. So this pancreaticoduodenal artery has to be preserved, and only the right gastroepiploic artery has to be divided. So this is the correct level of division, and this is not the correct level. So I'll just show that anatomy here, the terminal branches. So you can see here, this is the gastroduodenal artery, and this is the antero-superior pancreaticoduodenal artery, and this is the right gastroepiploic artery. So we need to take off only this for the station 6, and this should not be divided. Again, this is a case where you have a separate right gastroepiploic and the infrapyloric along with the antero-superior pancreaticoduodenal artery. So you can see here you have two branches. So one is a right gastroepiploic, other is a infrapyloric artery. And both these vessels are divided separately. So the first vessel has been divided, and this is the second one. So you have two vessels, and the antero-superior pancreaticoduodenal artery is preserved. Now, this is the other variant in which the infrapyloric artery originates from the right gastroepiploic artery. Now, in this case, you will have only a single vessel to ligate. The station 5, we know it's origin of the right gastric till its first branch. Now, there are two ways of approaching the station 5. One is by lifting the stomach and approaching it from the inferior aspect. Now, when we are doing this from the inferior aspect, we should be careful that we don't inadvertently injure the hepatic artery, because this is the hepatic artery. You have the gastroduodenal artery. Usually, in most scenarios, you will have the right gastric artery after the origin of the gastroduodenal artery. And it has to be ligated at this level. Sometimes what happens when you are doing with this inferior approach, now this is the hepatic artery. By mistake, you see this vessel and ligate it at this point. So which means instead of ligating the gastric artery, you will ligate the hepatic artery. That's why before ligating the right gastric artery, you should clearly define the hepatic artery proximal and also the hepatic artery distal, so that you inadvertently don't ligate the hepatic artery. And this is also one of the reasons why we define the gastric artery, but before ligating the right gastric artery, we go to the superior approach. So this is from the inferior, but we use a superior approach for ligating the right gastric artery to avoid this complication, which means you come from this aspect so that you don't inadvertently injure the hepatic arteries. We know that right gastric artery is most of the cases you'll be able to identify. However, the right gastric vein, often you may not identify it. And that's also one of the reasons why that is not used as a landmark for station 5. Usually the pre-pyloric vein, it continues as a right gastric vein and then drains into the portal vein. Occasionally, you can have a very prominent right gastric vein, which can be identified draining into the portal vein. So this is the approach of the safer approach of taking the right gastric artery, that is from the superior aspect rather than from the inferior. You can see also the right gastric vein there. And then it further drains into the portal vein. So this is now the dissection along the hepatic artery. You can see this is the hepatic artery, and this is the right gastric artery originating from the hepatic. And the right gastric artery is now being divided. So many times you will be actually, because there used to be a teaching that right gastric artery is often not present, but that's not correct, because in the minimalist approach, more than 90% of the patients, you will be able to identify the right gastric artery. And it's important to identify it, otherwise you will have bleeding, because failure to recognize it, you often injure it, and that results in bleeding. So this is what I was highlighting. This is the wrong level of ligation, and this is the correct level of ligation after identifying the hepatic artery distally. So the next is station 12A, which is actually the lymph nodes along the proper hepatic artery. If you see the definition, it is between the caudal half of the confluence of the right and left hepatic ducts and upper border of the pancreas. But actually, we don't strictly follow this definition of, because we don't actually measure where is the confluence and the caudal half. But what we do in practice is we go along the hepatic artery proper, take off the lymph nodes, and make sure we see the portal vein. That is, the left border of the portal vein should be visible. And that ensures the clearance of the 12A. So we go along the, you can see here, so this is the lymph node along the hepatic artery. And then this is the portal vein. So we make sure that we take off this node and we see the portal vein, the left border of the portal vein. You don't have to go posterior to the portal vein. For station 12A, you have to expose the hepatic artery and then take the lymph node on the left side of the portal vein. Now you can see here, so this is the hepatic artery and the left side of the portal vein is cleared, and this lymph node is actually the station 12A. Obviously, so we don't do all these lymph nodes separately, but we take them en bloc, but you need to have landmark for each station to ensure that that particular station is cleared completely. Next is station 8A. So you start from the station 12A, and then you continue along the anterior aspect of the hepatic artery. So this is, so the point to remember is we need to clear only the anterior aspect as part of the standard lymphadenectomy. You don't have to loop the hepatic artery and go to the posterior, that is the 8P nodes. That's not recommended as part of standard lymphadenectomy. So only those on the anterior aspect and the 8P is not generally, but however, if you have a significant node there, then we clear them. But if you don't, that's not a part of the standard D2 lymphadenectomy. The next is station 7. So after clearing the station 8, then we move to the station 7, that is from the origin. Now, generally, the artery, you don't have issue. So the point to remember is the left gastric artery is one of the earlier branches of the celiac trunk. So you have the celiac trunk. Most often, left gastric is the first branch. And afterwards, you usually have a short stump of the celiac trunk, and then you will have the hepatic and the splenic artery. The left gastric vein drainage is highly variable. These are the different ways in which the left gastric vein drains. Commonly, you either see them going posterior or anterior to the hepatic artery. And the next type is crossing either the splenic artery. And this is a very rare variant of left gastric vein draining into the close towards the hilum. Otherwise, in these two variants, you often see the left gastric vein draining into the portal vein. And in these variations, it often drains into the splenic vein. So you can see here, so this is the commonly you observe the left gastric vein draining into the portal vein, and it travels posterior to the hepatic artery. And when you have this type of a course, it usually drains into the splenic vein. So this is what, so when we do the lymphadenectomy, you do 12A and 8A combined, and then we come towards the station 7. So here we will be exposing the proximal part of the splenic artery, and then we go towards the left gastric artery. As I mentioned, left gastric artery is one of the earlier branch of the celiac trunk. So you will actually first go along the hepatic artery, see the splenic artery, and then you descend down, then you come across the left gastric artery. So this is the hepatic artery here. And you can see here, this is the splenic, left gastric vein. So you have the hepatic artery, you have the splenic artery. And in this case, you can see the left gastric vein. So crossing, so this is crossing both the hepatic artery and the splenic artery. And this is the ligation of the left gastric vein. So whenever it is crossing, you first take the vein, and then only you can safely divide the artery. So you need to be aware of this left hepatic artery originating from the left gastric artery. In that scenario, what we do is we clear off all the nodes till the origin of the left hepatic artery, and then you divide the left gastric artery distal to its origin. But make sure that all the lymph nodes are completely cleared of this segment of the artery. So the station 7 is the origin of the left gastric, and the station 9 is the lymph node around the celiac artery. So as I told in that publication, the station 9, the compliance improves with robotic approach compared to laparoscopy. It does not mean that you can't do with laparoscopy. Close to 90% of the patients you can still do by laparoscopy also. But there are a small subgroup where this lymph node station, the depth will be more, and there the articulation of the robotic instruments help. So this is station 7, and the station 9, for station 9, you need to go around the celiac, and only then you can clear the station 9. Very often, the station 9 is not cleared well with laparoscopic approach. So you can see.
Dr. Kalayarasan, we'll have to little bit expedite. Okay.
Yes,
yeah.
Yeah, I think
we have time for questions. Yeah.
Another probably 5 minutes, I'll finish it.
Sure.
So we can see here, so this is the the hepatic and the splenic, and then we going towards the left gastric. So you can see here for station 9, we are going around the celiac trunk. So only then you can clearly, so we actually join with this tissue which we have cleared on the left side of the portal vein. And we go around, so this also exposes the crest. So this is essential for doing the station 9. So when you are actually, we generally combine the station 9 and the station 7. But this is important, going around the celiac trunk, and then you clear off, then you ligate the left gastric artery. So this is actually ligating left gastric. You can again make out that this is the first branch and these are the terminal branches. So this is a very important anatomical point to remember. And lastly, we have this 11P. So the 11P is actually the proximal splenic. The boundary for us is the posterior gastric artery. So this is the posterior gastric artery. So you up to that you need to clear. So and there's a short video of the 11P, which is, you can see here, this is the posterior gastric artery which comes from the splenic artery. So up to that is the boundary for the 11P nodes. The 4SP is along the left. This is along the left gastroepiploid. We don't have to go up to the origin of the left gastroepiploid. So that's an important point to remember while clearing the left gastro, this 4SP nodes. And you often have a branch communicating with the colon, so which you need to divide before you take off the 4SP nodes. So you can see here, you can see one branch going towards the colon. So this is actually an arcade which communicates between the gastroepiploic and the colic vessel. And that you divide it, and afterwards you take off this left gastroepiploic vessels. So this is our level of division, and this is the communicating vessels. And lastly, the station 1 is along the ascending limb of the left gastric artery. So we need to clear off this. So the lesser curve has to be completely cleared, and then only you have to divide the stomach. So that's an important point to remember while doing this station 1, because this is again not cleared well. Many times when you do distal gastrectomy, we think the vascularity has to be preserved and we keep the tissues, but that's not right. You need to clear the station 1 node before you staple the stomach, because that's part of the distal gastrectomy. So you can see here, so completely we are clearing off, you can see the left lesser curve is completely cleared right from the GE junction. So because this is for the station 1. So this is actually the station 1 group of the lymph nodes. And the last, so I'm not going into the details. So you have the various options. So broadly, you have Wildroth 1 and the Wildroth 2 methods or the various modifications. In the East, since they have a good number of patients with the early gastric cancer, the Wildroth 1 type of reconstruction is very common. But in our Indian scenario, we often use the Wildroth 2, which can be either a loop or you can use a Roux-en-Y anastomosis also. I think with that, I'll conclude, sir.
Okay. Thank you very much, Dr. Kalayarasan, for such a wonderful lecture. Okay, beautiful illustrations and very nice videos and very clear demonstration of how to do lymphadenectomy for gastric cancer, for distal gastrectomy. Now, before we move on forward, any questions from the panelists, faculty who are on the panel? Any questions anybody would like to ask Dr. Kalayarasan?
So I wanted to ask, so that
Yeah,
was
please go ahead. Yeah.
very beautiful presentation with the amazing demonstration of each and every step, especially the lymphadenectomy. I wanted to ask you, do you always use a Hem-o-lok clip even for the small vessels, or do you end up using the metallic clips, or maybe just using a bipolar because of for the small veins?
Yeah, that's a good question, Dr. Deeksha. So When we do with robotic, we prefer to use a hemolog. That's because although robotic also has metal clip, but that's very small. So in robotic, the robotic instrument, if you want to have the control of clipping, then it's better to use a hemolog. But however, when we do by laparoscopic approach, then depending upon the vessel size, we either use the metal clip or the hemolog. And as you rightly said, for the larger vessels like left gastric, even a right gastric diploid, we use the hemolog. For the smaller vessels and the veins like for the right gastric artery, so you can still use a clip. But the main reason for using hemolog is because that's under our control. Otherwise, you have to ask the assistant to apply the clip. Sometimes the angle may not be suitable for them.
So in addition to the bipolar and the scissors, you have the harmonic and the hemolog at your disposal.
Yeah, so we don't use the harmonic for gastrectomies because that will be, I mean, that adds to the cost.
Right.
It's actually one of the reasons why we don't use robotic approach for gastrectomy that much. Actually, you can do most of these steps as good in laparoscopic also. Actually, I have a separate video because of the shortage of time. I didn't show that. You can do the same clearance with the laparoscopy also. So personally, I don't use much of robotic approach for gastrectomy.
Right, sir. Thank you.
Any other question from anyone else? I have few for you, Dr. Kalayarasan. First one, what you said, when you're using harmonic, conventionally when we are using a robo, we make it, especially in our exercise system, we have the T sort of ports what we place. But if for the harmonic, you said we are not maintaining the T,
Yes.
does it lead to any clash of the instruments when you're operating?
No, sir. It does not. As long as we maintain the sufficient distance between the trocars, usually the clashing does not happen.
That 8 mm distance between the two.
Yes, sir.
Okay.
6 to 8
Okay. Okay. Another question is, you have told at some points when you're doing lymphadenectomy that these particular lymph nodes, laparoscopy, you might have little challenges and difficulties. I wanted to ask you, because the talk is laparoscopy versus robotic. Overall, when you're doing you said very clearly at the end that even I felt that like what limited cases I've done with you for gastrectomy for robo, because the stomach is a very mobile organ. When you have a mobile organ for robotic, it becomes little difficult. So because we can't put additional ports also within the zone of those robotic ports. So do you think that there are any particular advantages apart from this lymphadenectomy which are superior compared to laparoscopic approach?
So actually, personally, as you rightly mentioned, so the handling the stomach, sometimes, especially if you have an advanced tumor, becomes extremely challenging with robotic, because the instruments are like in laparoscopy, you can have the option of bowel graspers, which are long. So, but in robotic, most of the instruments, except for the pro grabs, so they are actually the length is smaller, which is fine for most procedures. But for stomach, we do have challenges, especially while retracting. The momentum tends to fall. So that's one of the reasons when we do robotic gastrectomy, D2, we do the omentectomy part at the end rather than at the beginning. So we actually
You mean laparoscopically?
During laparoscopy, you can still manage. But
no, what I meant was when you're doing robotic at the end of this, you undock and do laparoscopic lymphadenectomy or the omentectomy, or with the help of robo only?
What we do is we actually just lift the momentum and ask the assistant to use the energy device and do the omentectomy.
Okay. Because what Dr. Deeksha asked, one of the problems with energy devices in robotic, what we have seen here, they're single use and very expensive. That is the reason that we manage everything with the monopolar scissor and the fenestrated bipolar. That's one of the reasons that we primarily depend on that for practically all our surgeries, is it not? That's what is the reason. But if you have those things at your disposal and cost is not an issue, then definitely the time which is required, blood loss, what you said, particularly everything what is mentioned in that paper, you can definitely achieve all those things with the help of a robo. And of course, the the difficulties what you have sometimes with robotic surgery when with you have these instruments, those also are overcome.
Yes.
So thank you very much, Dr. Kalayarasan, and for a wonderful lecture. And when we may have some more questions during the open house time, if we have enough time during that time, and if we have some questions there. So I've not received any questions particularly uh, from the viewers on YouTube at present. So we'll go on to the next talk. And the next talk will be by Dr. Sadaf Ali, who is Professor and Head Department of Surgical Gastroenterology at SKIMS Srinagar. And she'll be talking to us and sharing her experience on current standards of lymphadenectomy for carcinoma stomach. Dr. Sadaf Ali, over to you. Thank you. You can share your slides. I will verify whether they are visible or not.
It shows host as disabled participant screen sharing.
Can the organizers, can you make Dr. Sadaf Ali as the host, co-host, so that she can share? Presently, she is not a co-host. Organizers, anybody is there? Yeah, you have been made
Yes.
co-host. Thank you very much. Now you can share.
Uh,
Can you share the
Uh,
slide so that I can confirm that it is visible? It's not yet visible.
Is not yet visible?
No, it's not yet visible. Yes, I can't see it.
But this one. So I think it's shared now.
Yeah, it's visible now. Yeah, you can make it full view and then start. Yeah, you're audible also.
My apologies for having some hiccups as I did not check it early. I was busy with some meetings in the hospital.
No
So,
problem at all. Absolutely.
as
Please
a
go ahead.
part of continuation of management of gastric cancers, I have been assigned to discuss the current standards of lymphadenectomy for gastric cancer. I know much has been covered by the technical details spoken by Dr. Kalayarasan and previous speakers. A little brush up of what they had put yesterday, that all those lymphadenectomy standards evolve around the AJCC staging system, which puts the gastric cancer into early and advanced, where early is stage T1 and advanced are T2 to T4. And the nodes have the significance of N1 to N3, where 1 to 2 nodes are N1 disease and N2 is 3 to 6. And then N3 is 7 or beyond, where when 16 or more lymph nodes are involved, it is N3P. So what are the various lymphadenectomy described in literature? The lymph node drainage of stomach are classified basically at 3 levels based on the anatomical location of the tumor in context to stomach. So it is level 1 to level 3, and it is different for different areas of stomach, as we understand that the stomach is a large organ. The nodes in the first group are the perigastric lymph node 1 to 6. Those in second group are along the branches of celiac artery 7 to 11 plus 12A. And those in the third group are 13 to 16. So based on this, actually, we define the gastrectomy into D1, which involves removal of perigastric lymph node at tier 1. D2 is D1 plus removal of the lymph nodes along all parent vessels which supply the particular area. D2 plus is removal of the node beyond, designated as tier 2 for D2. And D3 has a little gray area, but it describes lymph nodes which are in N3 nodes. In addition to all this, subsequently, as a part of standards, station 7 is included in D1 dissection for all types of gastric cancer, all areas of gastric cancer. Now, what is the significance of I'll just short. This is obscuring. What is the significance of the adequate lymph node? The concept of complete removal of all lymph nodes likely to be involved is based on the site of the tumor, making a huge difference in survival, was first introduced by Japanese. They actually showed the world that there can be a significant survival benefit with level 2 lymph node clearance and labeled it as due to gastrectomy, as we all were discussing. It gained place to be as a standard in all surgical treatment in all major guidelines. And subsequently, there was introduction of D2 plus and D3 gastrectomy that may be required in certain subset of patients. This is not standard, but this was further consolidated with a lot of literature and evidences showing that the lymph node ratio and the rate of non-compliance lymph node clearance are very important prognostic factor. So more than cure, it actually hovers around prognostication of the disease. The lymph node invasion is the primary prognostic and prognostic factor of gastric cancer. Minimum of 16 lymph nodes are mandated to stage and prognosticate the disease. Removing even more than the designated is all the more welcome. There's a lot of study on this, and it's a core hope for better prognosis. Now, studies have demonstrated that the higher the lymph nodes examined and removed, it correlates to better post-gastrectomy survival, especially in stage 1 disease. The 5-year survival is assumed to be, is actually documented to be long back, not in the era of present NACT, which will be discussed by the later speakers, 70 to 80%, 30% in N1, and 5% in N2, which has improved after increasing the number of lymph node in resection. So actually the background of this concept evolved all over world once there was initiation taken by the European 3 trials, the famous the MRC, the Dutch trial and the Italian trial, which made an attempt to compare the standard D1 to D2, and subsequently after initial no early survival benefit and a low level of agreement to the procedure shown by Japanese. After 15 years, they poured in more data that it is definitely better when compared to D1 in subset of patients who have an advanced disease. The Italian trial showed benefits both at 5 years as well as 15 years. The D1 group had at 5 years 59% survival versus 38%, and on subsequent follow-up, the disease-specific survival and the mortality related to gastric cancer was significantly low in D2 group when compared to D1. So they proposed that if the morbidity can come down, because they had a lot of morbidity, which they assumed to be related to 2 factors, the training or the skills of the surgeons in the European subset when compared to Japanese, understanding of D2 gastrectomy, as well as contributing it to removal of distal pancreas and spleen as a part of the procedure. Then poured in many more randomized controlled trials coming in from East, backed by China, Korea, Taiwan, which looked into D1 versus D2. So what is peculiar over here about the lymph nodal dissection is that this kind of studies actually showed clearly that the morbidity is not and the mortality is not, which was shown by the European world. But the D1 and D2 are almost at par with the survival, except for 1 or 2 exceptional studies which showed reverse. And this is how now it's a standard practice and gained a place in your NCCN guidelines, where the disease of early gastric cancer needs endoscopic resection Or in medically fit candidates, it might need a surgical procedure mounting only to D1, and those which have disease beyond, the standard is perioperative chemotherapy followed by D2 gastrectomy. So is the European guidelines, believe in multimodality modality treatment in all advanced gastric cancer. And but a little difference should be discussed over here about the Japanese guidelines, that they don't give away with M1 disease, and when it is M0, their protocol is that early gastric cancer is endoscopic, as well as if it is, they recommended is if the disease is into the submucosa, then a D1 or D1 plus gastrectomy would be more appropriate, or if you cannot do it for the mucosal resection endoscopic, as well as they also recommend that all those patients who have T2, T4, if they don't have bulky lymph node, D2 gastrectomy is appropriate. But if they have bulky node, they go for NEC followed by D2 and even D2 plus lymphadenectomy. For M1 disease, they recommend that there should be if it is a resectable liver metastasis, and if the disease is in the circle of N4, because they put it a little differently, N1, N2, N3, which I'll come down later on. They recommend a post neoadjuvant chemotherapy, consideration of D2 gastrectomy plus a periaortic lymph node resection. You can put it as D3. Some of them also put it at D4, and the others go for palliative care. So there's a consensus now by almost all guidelines. If you see the French, the NCCN, the ESMO, and the Japanese, that all those patients who are advanced will require a D2 gastrectomy, and those who are early would require an endoscopic or a D1 gastrectomy. But the Japanese still prefer a splenectomy to be added in the greater curvature tumor, and the French add it when it is T3 or T4 tumor over there. So the standard of lymph node dissection now is definitely D1 for early disease, T1A and 0, and anything beyond would require D2, D2 plus, and D3 is for bulky nodes. And once there's a clear evidence that there are lymph nodes at level 3. So just a brushing up and for the knowledge of students, we have already discussed yesterday, as Kalayarasan showed, that it's not that station 4 is station 4, which can be generally named, but you have to understand it in context to what are the parts of station 4 lymph node, what you have to leave and what you have to take away. So this is what is they describe as N1 up to station 6, N2 up to 11, 12 to 14 are N3 level node, and N4 are the lymph nodes, which are 15 and 16. So a good D2 gastrectomy, whether open or laparoscopic, should have a clear view like this, that you have cleared all your stations 7, 9, 11P, 8A, if required, add 8P, and the 12P and A. What is different in different site of the tumor is when you're planning a D2 gastrectomy for a different level of gastrectomies for a total gastrectomy demanding tumor, say the tumor is somewhere in between, then all D1 has to go away, which is in blue. So all 1 to 6 goes away in a total gastrectomy. In D1 plus, you have to add the station 7. Plus 7, and D1 plus you have to add station 8A, 9, and 11P, which is then in the orange color over here. And in D2, you add in the total gastrectomy the 11D and the 12A. Now coming to a distal gastrectomy, which is more commonly and simply performed, it is mentioned over here about D0 because it's all based on skill and the understanding of the procedure. Many beginners assuming even a D1 gastrectomy misunderstand the specimen of D0 with missing lymph nodes, as he said, in G junction, and there are some difficult lymph nodes especially in laparoscopic and demanding surgeries. So D1 in distal gastrectomy include station 1, 3, 4SB, 4D, 5, 6, and 7. So the station 2 and the short gastric area may be spared, and D1 plus would add 8A and 9, and the standard D2 would also have 11P and 12A included. For proximal gastrectomy, there aren't many proponents, but those who believe in organ preservation in STIWA type 2, type 3, and some smaller lesions, you have to go for a standard D1 would be 1, 2, 3A, 4SA, 4SB, and 7. And D1 plus will include 8A, 9P, and 11P over here, which is different from the other. They are the blue and the orange. And a standard D2 will also include the station 11D in addition to this, the distal node along the splenic artery. So how we go about it in the open procedure is, if you see, this is almost a T4 lesion, and this patient is, can I just take it forward with my cursor? Yeah. So unlike what he said that they leave the omentum to the last, we have good place for traction, and we do it early in the procedure. And then we move on up to distal gastrectomy. So once we mark an area where we need not collect lymph nodes from, they all come station 1 along with the omentum. And then the right gastric stem, it's very important that we take pedicle kind of a nodal tissue rather than taking it away in picking up and taking it away in piecemeal. This is what we had discussed yesterday also. So coming to the after division of the lesser omentum and greater omentum, then you start dissecting, do away with the duodenum and create a traction, and then you start appropriate D2 clearance. Here, it's very important that you meticulously use your energy devices. If you are a beginner and you are likely to post-fire, pass point, then this kind of electrocautery may not be recommended. It would be good if you use bipolar energy sources, which can be more focused and causes less collateral injuries. The nodes are to be separated in en masse, and we have to start, usually the dissection starts, as you said, along the common hepatic artery, and you tend to clear all the tissue. You avoid breaking the tissue and taking it into piecemeal, and most of the time it's not very difficult to take the posterior part of the nodes, stepping up with more lymph node gain. We on an average usually get, as we progress doing it, and it's a state where the disease is very common, from we are not restricted to 16 nodes. Usually on an average we get 25, 28 lymph nodes in a specimen. So the staging is quite adequate if the lymphadenectomy is done in an appropriate and proper way. And then you move to the left gastric after doing the celiac, the proximal part of the splenic, the common hepatic, and if required, if you find a positive node, go posteriorly. If you find a positive node, then you should also go to the hepatic artery based on your planned gastrectomy if you want to do beyond D2. There's absolutely nothing about, if you master a procedure, having a lot of post-operative lymphoria, because what we believe in is that the stump of the disconnections at the base, we tend to put some amount of ligatures or liga clip. So rest is the usual way that you decide where you are going to, where you are going to do your level of disconnection and reconstruction. Now, something more about the standards of lymphadenectomy, what we have to do in patients with early disease, T1 and 0, but you have to do a D1 plus when the tumor is more than 1.5 centimeter, the tumor is poorly differentiated. You have to extend it to inclusion of station 8A and 9. And in cases of total gastrectomy demanded in the smaller lesion, you have to include the 11P. So it becomes a more extensive procedure. And you have to consider D2 plus in certain areas again, in where you otherwise would have done a D2, especially in patients with those who have tumor which is bulky on the greater curvature and in close proximity of hilum, you need to remove hilar node, and sometimes it may end up removing a spleen. And D2 plus may also be required in patients who have distal malignancy, where you have a definite or confirmed or obvious station 6 node involvement. Then you should think about removing the 14V lymph node, which is along the superior mesenteric vein. And if you have a duodenal invasion in distal gastric cancer, there are recommendations, though these are not standard recommendations or inclusion in guidelines, but you should take the lymph node, which is 13P, which comes along the posterior side of the duodenum. So then if you have an obvious extensive lymph nodal disease and it's an advanced disease, a diffuse involvement of stomach, and you're doing it post-neck, you can go stage it up to D3 and involve the stations 16 nodes in your dissection. So consideration of the periaortic lymph node is based on the argument that if D is more than N, the recurrence is likely to be less. And the periaortic nodal involvement is usually seen if you based on studies in 30% of the patients, and you to target them. Otherwise, it will eliminate the stage migration. And then, but this is not backed up with addition to survival data. Initially, when Japanese showed interest in this, they could not document survival benefit 69 versus 70 in D2 and D3. And subsequently, at present, recent years, there's a renewal of Japanese interest in picking up D3 lymph nodes for tumors which are more than 5 centimeter. There's a recent phase 2 trial wherein they have reported that with inclusion post-neck, the periaortic lymph node, the survival is quite good, 53%, 59% at 3 years and 53% at 5 years. So usually what we see, the trend of survival is a good gastrectomy actually shows the survival benefit at longer term. And even the gastric cancer study group recommends it to be considered in diffuse type of lesion. Now, a word about these kind of the literature support. There are people who have studied on it and concluded that there is a better survival in patients who have definite involvement of 14B, and this should be included in the dissection of D2. And what exactly is the node is the node over here at the root, and we have to, along the superior mesenteric vein, you have to identify and remove it. Now, when you look into data of D2 plus, there are few meta-analysis where people have tried to look into it, and they have said that there is a survival benefit if removed and assumed to be positive with over 5 years. And they have also shown that D2 plus, if you involve those concerned lymph nodes, the disease pattern of involvement is proven to be in 7% 8P, 5.1% in 12P, 13% in 5.7% in station 13, and again 7.1% in this is one among those meta-analysis. And regarding periaortic lymph node, again, it is all depending upon those which have positive, confirmed, and those who are negative. If they are positive, there is a trend towards survival benefit, but you may end up removing the lymph nodes which are not actually positive. So this study in green actually has taken into consideration those who were proven to be pathologically positive, and dissection of those kind of lymph node actually takes it up from 13% to 28%. How do we take a call about going beyond D2 gastrectomies if you see a positive lymph node, something like this at the root, and if the tumor is otherwise resectable? So we look into the area. In fact, we are actually doing a study we could up very
Dr. Sadaf, you'll have to explain. Yeah.
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 So
Sorry
we
to
have
interrupt.
if you are into the periaortic lymph node clearance, you should be knowing that what lymph nodes are to be removed. A1 and B2 are not the lymph nodes, but you have to take the A2 lateral and internal and B1. So the concept now a little bit about, I'm just finishing concept of sentinel lymph node mapping. It's also important when you discuss the lymphadenectomy with context to doing away with unrequired kind of lymph nodal removal. This gives you an exact navigation and helps to remove the actually required node and give an equivalent results of standard D2 gastrectomy. This is also likely to add organ preservation. There has been a meta-analysis which has proved that the radiocolite tracer with dye injected within the tumor can actually guide you to correct navigation in 82 to 88% of the cases. It has a definite role in early disease T1 and T2 with low nodal burden, which can be picked up with good CT or EUS, and this can be tried. Recently, there's also an interest in using ICG to be promising in this field, and it has a better role to be played in minimal invasive surgery. So I'll just keep away with some studies and logical results which they have shown with a better a good result or at par result in group of those navigated and non-navigated. Of course, the inclusion criteria are strict. So, for example, what they have put up in their study is that what you end up in removing so many lymph nodes and the so much of tumor, you can actually preserve and remove very little over here, and there can be an organ preservation as well as lesser morbidity. And then we have already discussed, they have already discussed whether it can be translated into the laparoscopic or the minimal approach. We have less results of the robotic, but we have good amount of results of early gastric cancer in laparoscopic approach. These are the Korea and the Japanese, the class trials, still ongoing trials, which he gave a little reference. But in early gastric cancer, it has a similar role. But once you have to do an extensive lymphadenectomy, there's a lot of heterogeneous results reporting, which says that it's very difficult or there is a low threshold to have a compliant lymph node in station 4, 6, 9, and 11. And some of them, they also report it to be on station 4. But then we have to have go with the present this thing, and in experienced hands, it will have a similar result. So I would summarize that I did not put up any take-home message that you have a primary tumor and an early disease, then D1 lymphadenectomy, the circle increases as the disease is advanced, and you go to D2 for metastatic disease. There is still a role of D2 plus and periaortic lymph node in subset of selected subset of patient. And of course, you have the red area where you don't have much to offer. Thank you, everybody, for your patient hearing.
Thank you very much, Dr. Sita, for such a very comprehensive lecture on the standards of lymphadenectomy in gastric cancer. The panelists, one or two quick questions because we're a little bit short of time. Any questions from the panelists? The presentation can be closed, Dr.
Yeah.
So that you will be visible on the screen.
Can I just start with the question?
Yeah, please.
Nice presentation, Dr. Sadaf. You mentioned about the use of ICG in guiding the lymphadenectomies. So it has been known to be useful in early gastric cancer. So what is your opinion on advanced gastric cancer? Because I just share with because we thought we'll did a pilot study, but what we have found is many times in advanced gastric cancers, the ICG does not go beyond the initial enlarged nodes. So our idea was we'll use ICG to find lymph nodes that are beyond D2 so that we can selectively do those D2 plus. But that was not, I mean, helpful.
Exactly. At present, it is all a navigation of early gastric cancer and maybe some in between stage with low nodal node. But if you are expecting an extensive nodal load, then it might not be good. But it's all in primitive phase. I think your center is a better center. You gave carcinoma gallbladder ICG navigation also some time back. I had seen somebody presenting. We don't have any experience in doing it, but this is what is maybe the way forward.
Thank you.
Thank you, Dr. Kalayarasan. Any more questions? Okay, I have a question from the participants who are viewing this program. Dr. Sadaf, this is from Dr. Vihar Kotecha. How far would a lymphadenectomy go for a distal gastrectomy T3 disease with no nodes in 1 to 4 in the tier 1 nodes? Will you take 1 to 3 nodes too? That's the question.
See, for distal gastrectomy, one has to come because the arc of the lesser curvature is so short that we always remove station 1. Once it is a question of station 2, the stump in subtotal gastrectomy, usually you do subtotal, and the station 2 are cleared, but you have to take care that you don't take away the vessel. So station 2 and a part of even 4 short gastric may not be required, are not required actually, even in a part of D1. So it's exactly where the tumor location is. So tumor location is distal. You have to know that what is its basin 1 and what is its basin 2. Again, its level 2 are different. Its level 2 will not include a splenic hilar lymph node. Its level 2 will include the lymph nodes which are along your hepatic artery. Maybe sometimes if you want to go beyond, you will go behind the common hepatic artery and the hepatic artery proper. And the distal gastrectomy, as I discussed earlier, it's a very, very, the core of the chunk of the lymph nodes are in the station 6. So you have to be very careful while removing the station 6 nodes. None of the lymph nodes should be left behind because that's a primary or the tier 1 lymph node. And once you are done with station 6, you should have a very vigilant inspection that there some lymph nodes along the 14V. So 14V might be required to be removed, which is not a part of D2, but it would definitely add if it is positive. Then if it is negative, it doesn't have much to do. But if it is positive, then you are doing away with disease, which might be left behind. But that would become a D2 plus gastrectomy. Hope I answered that question.
Yeah. Thank you very much. One question from my side. You have told that in early gastric cancer, we can do D1. Are there any other setups in locally advanced gastric cancer where D1 might be necessary? Necessary in the sense that D2 may be difficult or challenging.
It might be difficult in patients who are morbid. So if you are not able to do an extensive procedure, if the expertise is less, say if you are doing a gastrectomy, I have done quite a few patients with D1 gastrectomy who had frank Child's B cirrhosis and CA stomach. And you cannot give, based on that, you cannot produce evidence, but you have few cases who actually do very well, even with D1 gastrectomy. So we
What
have been...
about emergencies?
Yeah,
Patient
in
bleeding.
a bleeding emergency case, if the expertise is... So the level of skills in D2 gastrectomy is... maybe you say in at the level of what you are doing right now, and for the beginners and the junior faculty, they may end up doing a D1 gastrectomy in emergency. But then you have to take into consideration that if you can do a limited D1 plus, this is always in favor of patient. Another indication would be they recommend it for stage T1B to do D2. But if the tumor is smaller in size, say if it is 1 centimeter, then a D1 gastrectomy may suffice.
Right. So just to summarize, maybe when, as you said, mobility is there, very elderly patients who may not sustain a prolonged operation, or in emergencies when things are compromised, we may have to step down and consider a D1 instead of D2, even if the expertise is available. Okay, I think thank you very much. We'll go on to the next talk now. by Dr. Deeksha Kapoor, who is a consultant GI surgeon at BLK Max New Delhi, and she'll be discussing an overview of the management of carcinoma stomach, because yesterday we have covered some topics, today we have covered, but everything cannot be covered. So that's the aim. So we have given her a task of giving you an overview of the management overall, what has not been covered essentially in these individual talks. So Dr. Deeksha Kapoor.
Thank you, sir. Good evening, everyone. A big thank you to the organizers for involving me in this program. I hope I am able to do justice to the time and the topic that has been allotted to me. So I'm just going to bring things into perspective for a moment here. Between yesterday and today, we've already discussed the anatomy of the stomach, the lymph nodal stations and the drainage, the diagnosis and the staging modalities, use of minimally invasive techniques, robotic and laparoscopy in surgery, and the status of lymphadenectomy, the discussion just by Professor Sadaf right now. So I'm going to fill in the blanks, things which have not been discussed so far, and I'm going to focus on these three. The role of neoadjuvant therapy and adjuvant therapy, and how we factor in surgery, and how do we place and create our equation to give the patient the best possible survival outcome. This is the SEER database graph from 1973 to 2005. This included data of some 11,000 patients. And I want to bring into perspective over here that the moment the graph touches stage 3, the survival at 5 years falls below 20%. So less than 1 patient out of 5 is going to be alive. This was what was projected in 2005 at the time, where multimodality treatment was actually not the standard of care. And therefore, this led to what we know now as the treatment paradigm of CA stomach. We largely look at CA stomach separately for cardiac tumors versus non-cardiac tumors, and I am going to restrict the talk to non-cardiac tumors. There is a lot of overlap when we talk about this. The most important trials that come, that's FLOT, MAGIC, etc. There's a lot of overlap with lower end esophagus, G, junction, cardia, non-cardia, but we will see what the numbers talk. If I have to put everything in one slide, this is the moral of the story. Gastric carcinoma, T2 and above, N positive, surgery alone is not enough. You want surgery and systemic therapy, which works better than surgery. Now, like I said, there are various ways we can factor this in. We can talk about adjuvant chemoradiotherapy. We can talk about flanking surgery with chemotherapy on either sides, that is perioperative therapy, and adjuvant chemotherapy. We will discuss the evidence that has been laid down by these seminal studies and see what sense we can make out of it. So the aim of this talk is going to answer these 6 questions. Is surgery alone enough? Why do we need systemic therapy if we have done a good operation? How good is surgery plus adjuvant therapy? What is better, chemo plus surgery plus chemo, or surgery plus chemo? Chemoradiation is required for which patient and in which setting, that is neoadjuvant or adjuvant, and surgery first can be done in which patient. So the first thing, surgery alone is not enough. So let's just remember the graph from the SEER database. At 5 years without multimodality treatment, the survival drops below 20%, and this is shown in these major trials. In 2001, McDonald's et al. Showed that with surgery alone, the survival was about 24% at 5 years, but with adjuvant chemoradiotherapy, it jumps to 40%. This is the Intergroup 0116 trial, which we will talk about again. The perioperative MAGIC study also showed the same, that with perioperative therapy, the survival jumps at 5 years to 36%, and the FLOT4 German trial, phase 2 and phase 3, gives the difference between the outcomes of ECF versus FLOT. So at least we need adjuvant therapy after doing a reasonable operation for carcinoma stomach. Again, I want to bring into perspective what the numbers are talking about. I already mentioned the results of the SWOG Intergroup 0116 trial. This was the trial which put adjuvant therapy into perspective. It just put adjuvant therapy on the map. And it said that chemoradiotherapy improves overall survival compared to surgery alone. Then came MAGIC, which spoke about 3 cycles of chemotherapy before and 3 cycles of chemotherapy after surgery, which improves survival. And we have a lot of data from the East, which says that S1 improves overall survival as well. The classic trial was actually looking at adjuvant therapy with Capox, capecitabine and oxaliplatin, and that also said that there is a difference in the survival curves that we see over here at 5 years, not just for overall survival, but also for disease-free survival. So moral of the story, point number 1, surgery alone is not enough. T2 and above and any node positive, it is prudent to give chemotherapy. Then the next question comes that initial surgery versus perioperative chemo, which is better? Now, perioperative chemo has certain advantages. We will talk about this alone, but if we have to just put it down to enumerate it, perioperative chemo improves survival. There is some element of downstaging of the disease. It addresses systemic disease and micrometastasis early on in the treatment paradigm. It has a role in evaluating disease biology and the sensitivity of the chemo agents which are being used. So basically, if the tumor is not responding, it gives us the chance of changing the therapy into a second-line therapy, either in the preoperative setting or after surgery, which the test of which is not possible if you've not given the patient chemotherapy in the pre-op. The fact of the matter is, which is interpretation of the data from various trials, that about 60% of the patients following surgery are going to start adjuvant. So about 40% will actually not receive multimodality treatment. And therefore, there is a benefit of giving some amount of chemotherapy to begin with before operating. There is substantial data to suggest that distant failure occurs in about 2/3 patients. So we know that even if we do a good operation, good amount of patients are going to come back with recurrences, therefore justifying the systematic effect of the disease and chemotherapy before an operation. Let's look at the MAGIC trial. MAGIC trial actually changed the way gastric cancers were treated. This was a 2006 study which put into perspective the triple agent regimen, which is epirubicin, cisplatin, and 5-FU, 3 cycles before and 3 cycles after surgery, and looked at survival outcomes. So if we actually look at this patient characteristic table, although there was involvement, the patient population included stomach cancer patients, lower esophagus, and GE junction. About 74% patients on both the arms were CA stomach. So it showed that at 5 years that there was a substantial difference in the percentage alive, 36 versus 23 with chemo. Now the fact of the matter is that a good number of patients did not receive adjuvant therapy. But even despite completing adjuvant therapy or the total 6 cycles, there was a benefit in survival. The FLOT4 is the next trial, which has actually changed the entire paradigm of managing CA stomach. The phase 2, phase 3 trial was reported in Lancet 2019, which the primary outcome of which was overall survival. This is also a triple agent regimen, which requires 4 cycles of FLOT before surgery, given at 2-week interval each, followed by 4 cycles of FLOT, again at 2-week interval each after the surgery, versus the ECF 3 cycles on either side of the surgery. This showed that the overall survival actually was better for FLOT. So we are comparing 15 months versus 35 months with an improvement in the hazard ratio of death with FLOT. Not just that, the progression-free survival was also with FLOT. There have been some concerns about the toxicity of FLOT when it comes to ECF compared to ECF. Though grade 3 and grade 4 complications were seen both, but the incidence of symptomatic neutropenia, grade 3, grade 4 neutropenia was higher with FLOT, which is something that raises a concern. So the next question is perioperative therapy plus surgery. Is it better than surgery plus adjuvant? So although a lot of this data comes from the West, that is the previous trials that we have talked about, MAGIC and Classic, etc., This is data coming from the East. The East, Chinese, Koreans, Japanese, they are high proponents of doing a radical lymphadenectomy and therefore saying that they don't require preoperative therapy. But these two studies were large-scale studies with a large sample size, which again went ahead to said that chemo, surgery, chemo, CSC, improved progression-free survival versus surgery chemo alone. So if I have to put it again, 3 hard points: perioperative chemo plus surgery is better than surgery plus adjuvant therapy. FLOT is better than ECF. And in poor performing patients who will not be able to tolerate a taxane or epirubicin, dual agent can be preferred over triple agent, which is basically a good patient selection. Then the question comes, what is the role of radiation? Now, this is the SWOG intergroup 0116 trial by McDonald et al., which is, like I said, which was the first trial which put the concept of adjuvant therapy in CA stomach on paper. This is a widely quoted and widely cited trial which said that if the patients received chemo radiation in the adjuvant setting, because their observation was that about 70% patients will develop a local recurrence, there is a benefit in survival. And they did show that the 5-year survival, the median overall survival, the disease-free and the overall survival at 3 years were all better. But there are certain caveats to this. Although it did go ahead and say that there is better overall survival and recurrence-free survival with adjuvant chemoradiotherapy, they set out to actually perform a D2 lymphadenectomy for all patients. But when they went back and checked their operative notes and operative specimens, they found that only 10% of patients had undergone a formal D2. So this first extensive data went to suggest adjuvant therapy helps, adjuvant chemoradiotherapy helps, but chemoradiotherapy has a significant role to play, especially when the lymphadenectomy is inadequate. Then the next question comes, adjuvant chemoradiotherapy is required in which patient? This is again extrapolated data from a lot of these studies, the SWOG intergroup 0116, CalGB, ARTIST-1, ARTIST-2 critics, and even the Dutch trial, that R1, R2 resection, inadequate lymphadenectomy, and even if a good lymphadenectomy has been done and the lymph nodal burden is high, there is some benefit of giving radiation to take care of the local recurrences. The next relevant question, of course, is, can radiation be used in the preoperative setting? So the Top Gear trial actually went out to see if there was a benefit in giving radiation before operation. Given that there was a benefit of giving radiation after the operation, like the SWOG intergroup, but they found out that there was no improvement in overall survival, although it did increase the complete pathological response rate from 8% to 17%, but there was no translation of this benefit into overall survivals, but the complication rate was similar. But chemoradiotherapy in the preoperative setting cannot be just rejected and put into a dustbin. In locally advanced unresectable tumors to start with, there is some benefit of giving neoadjuvant chemoradiotherapy and then reassessing if we can actually take the person towards a resection. This is data which was recently presented at the ESMO 2024 and the ASCO 2024, which looks at the RENAISSA trial, which is a trial for stage 4 gastric cancer patients, which randomizes patients with oligometastatic disease after 4 cycles of FLOT to receive either surgery followed by 4 to 8 cycles, or to continue with chemotherapy and put the patient out of an operative arm. This, I would like to bring into perspective what Professor Sadaf said in the previous talk about the survival data for retroperitoneal lymph node resections when RP-LND is required in CA stomach. So they went ahead and defined limited metastatic status. I just want to point out that this is data, I haven't found the publication. This is data that I have extracted from the abstracts, which are available on the websites of ESMO and ASCO. So it says retroperitoneal lymph nodes, which is parapancreatic, retroduodenal, mesenteric, retroperitoneal lymph nodes, and or at the maximum one another organ with or without retroperitoneal lymph nodes. So it has to be either localized, potentially operable peritoneal disease, at the most 5 lesions in the liver which are potentially resectable, unilateral lung disease which is resectable, uni or bilateral Krukenberg's tumors in the absence of peritoneal mets or disease elsewhere, and unilateral or bilateral adrenal mets. This is what they meant by limited metastatic status. And they showed that in the 2 arms, that is to continue chemotherapy or to give surgery and then chemotherapy, in the overall cohort, there was no significant difference in the survival. So here it shows a log rank p-value of 0.8, suggesting that there is no difference. But when they did a subgroup analysis, the maximum benefit was actually found in the lymph node positive patients only. So only patients who have retroperitoneal lymph node positives, which actually can be seen in up to 30% patients with so-called localized CA stomachs, in which you will not find solid organ mets anywhere else. There is a survival advantage of first giving chemo, making sure that the disease is responding, doing surgery and an extensive lymphadenectomy, and then continuing chemo. So this one shows an improvement in OS of about 1 year. But the same thing was not actually reflected in patients with either liver metastasis or peritoneal metastasis. So patients who had extensive peritoneal metastasis and underwent surgery, actually the survival was detrimental. So it says 12 months versus 19 months. And there was no difference when the patients with liver metastasis were offered surgery. Actually, the complications in these 2 groups were also higher compared to the complications in the lymph node positive group only. This is my last slide, and I am just going to summarize what all we have said. So T3, T4, N plus patients, surgery alone is not enough. We have to give these patients chemotherapy after a good surgery. The tenets of a good surgery and an adequate lymphadenectomy have already been addressed by previous speakers. We address systemic disease with systemic therapy, and we want to do that early. So most patients should get chemotherapy before surgery in CA stomach. If for some reason preoperative therapy has not been given, adjuvant therapy is indicated after surgery. Chemotherapy alone if the lymphadenectomy has been adequate. Chemo surgery, chemo paradigm is much better than surgery followed by chemo paradigm. And FLOT has a survival advantage over ECF, even when adjuvant therapy is not completed. If in case of poor surgery, we must add adjuvant radiation. Poor surgery means R1, R2 resections, inadequate lymphadenectomy, and extensive lymph nodes positive even when adequate lymph nodes were removed. Clinico-radiological T2 node negative or patients who have a complicated disease that is presenting with a bleed or presenting with a perforation or gastric outlet obstruction, which is not allowing patient to receive chemotherapy. Surgery first is an option, but that better be undertaken with caution and not as a routine plan. Surgery in stage 4 gastric cancer patients has gained momentum. We have the data now, but it is super duper selective. Thank you.
Thank you very much, Dr. Deeksha. You can close the presentation.
Yes,
Thank you very much for a very comprehensive, detailed, evidence-based talk. Especially, can we mute? Yeah, that's better. So that you have covered primarily the chemotherapy part, which was not included in any of the talks. Now, any of the panelists would like to ask any questions. It is open for discussion.
Excellent talk, Dr. Deeksha.
Thank you, sir.
Regarding the chemo, so you mentioned the FLOT as of now remains the first line in a fit patient. So what's your opinion on because still it doesn't become popular in the East. If you see the trials from the East,
Yes, sir.
they use SOX, S1 with oxaliplatin, or the docetaxel with PEX. I mean, there are various other regimes, alternatives for FLOT, which are being explored. And now even S1 is available in India also.
Yes, sir.
So what do you think in a fit patient? So should we still giving FLOT, or can we try the other regimes also?
So I think in a fit patient, it makes more sense to me to begin with FLOT. In the adjuvant setting, one may end up changing to S1 for a lot of reasons, but which I have seen, which I have done, but I would rather begin with FLOT. Just I want to point out over here that if we look at the data coming from the West versus data coming from the East, there are very obvious biases which can be seen across various organs. Western people always want to give chemotherapy first. Eastern people always want to operate first. And there is a very huge bent on using S1 in Japan and in the Eastern countries. And obviously, so it's available to them. It's been working for them for a very long time. And of course, the sentiment that they are more aggressive surgeons than the Western surgeons. So there is this data which is biased in these directions. And we need to make most sense what suits Indian patients because they fit into neither groups, I feel. So just to draw a parallel, yeah, I would start with FLOT. But yes, in the post-operative setting, I may consider S1, but I would try and give FLOT as far as possible.
Thank you.
Thank you. Any other panelists would like to ask any question? Dr. Deeksha, could it be a reason that in the East, many of the tumors are more advanced, and many of the tumors, like South India, we have esophageal and gastric malignancy, extremely common. So many of them come with obstructions. So how do you manage? Like, it's very difficult to put stents or something and then give neoadjuvant chemotherapy. So what are your thought about that? Is that one of the reasons that it goes into adjuvant setting rather than neoadjuvant setting?
So that is there. It's not possible in India to ignore the socioeconomic aspect of a disease. In an ideal setting, if it were possible to keep the patient in an institutionalized follow-up, there is some value in putting in a nasojejunal tube, giving therapy first if the patient tolerates, and then operating. But it is a good proportion of patients in which it's not possible to do that. And therefore, these patients end up being offered a surgery first and then chemotherapy. But just want to bring a point over here that, like ma'am also said, there is a lot of value in trying to do a good D2 lymphadenectomy, even if we are operating for obstruction. That does have a difference in the survival outcomes for the patients.
Thank you. One last quick question. Okay, before I go, actually, I should ask that question to Dr. Anushri because she's a radiation oncologist, but because you covered chemoradiation, you said the first trial, 2001 trial, okay, that's a post hoc analysis which showed that it actually benefited in patients where less than D2 gastrectomy was done. And right now that has become one of the indications for post-operative this thing. In the adjuvant setting, you give radiation therapy. Otherwise, most of the trials are not finding any benefit of radiation therapy. So what is the consensus right now about radiation therapy in the adjuvant setting?
Yes, sir. So inadequate lymphadenectomy, less than 16 nodes harvested, not a proper D2, are
So let's say
positive.
everything is done.
Yes. So
No,
in that,
surgery is perfect. Then is that
so
included?
there is some data to suggest that a high lymph node positive burden has some benefit of receiving adjuvant radiation. That
But
data
in
sorry,
general, no, no, is it not? In general,
no. In general,
okay.
no. So
Fine,
our
fine. That's what I think we'll go to the next speaker because she's a radiation oncologist. Okay, it will not be fair to discuss too much. So now thank you very much. Excellently covered, Dr. Diksha. And now we go on to Dr. Anushri, who's a consultant radiation oncologist on the home ground, that is Mahatma Gandhi Medical College and Hospital, Jaipur. So she's going to talk about one aspect that many of us face, and then we find it difficult to manage that when you have a gastric cancer which is bleeding. So she'll be primarily focusing on the role of radiation therapy for the control of bleeding from carcinoma stomach. So Dr. Anushri, please.
Thank you, sir, and thanks to the organizers. So this is a small presentation on the role of radiotherapy in carcinoma stomach to control bleeding. So gastrointestinal malignancies, they account for around 2 to 8% of the upper GI bleed events, and bleeding not only compromises the quality of life, but can also result in a life-threatening condition. So control of bleeding is very important. So let us start with a case. So a 27-year-old male diagnosed as metastatic CA stomach in January 2024 and with bone and liver mets. So he was planned for palliative chemotherapy, and after multiple lines of chemotherapy, which he received till May 2024, in June, he presented to us with fatigue and blood in stool. And on evaluation, his hemoglobin was 5.8 gram percent. So he was transfused, and so his hemoglobin came to 8.3 gram percent. And then again in July 2024, he presented with similar complaints. On evaluation, his hemoglobin again dropped to 7.5 gram percent. And when we did a upper GI endoscopy, it showed an ulcero-proliferative growth in the antrum with an overlying clot. On examination, his performance status was 2. So let us discuss what treatment options do we have for him. So any patient who presents with gastric bleeding, we have 2 options, either surgical or non-surgical. And in surgical, we have palliative gastrectomy. In non-surgical, the most preferred treatment is endoscopic methods, which has a success rate of 31 to 100%. Then we have embolization, which has a success rate of 40 to 100%. And the third option is hemostatic radiotherapy, which has a success rate of 50 to 80%. Now, since there are no specific guidelines as to how should we manage a patient who presents with bleeding gastric cancer, this strategy has been proposed by Kawabata et al. And they have suggested the non-surgical methods. So any patient who has active bleeding and has Forest 1A or 1B, endoscopic therapy are the preferred modality to treat such patients. And if it is successful, then to consolidate the gains, we can go for palliative radiotherapy. However, if it fails, then for patients who are hemodynamically stable, we can go ahead with radiotherapy. But if the patient is not stable hemodynamically, we should go with embolization, since radiation does not have immediate effect. And for patients who present with inactive bleeding, palliative radiotherapy is an option. So what is hemostatic radiotherapy? So hemostatic radiotherapy, it is a non-invasive treatment using ionizing radiation. So ionizing radiation are what? These are high energy X-rays, which are used for the treatment of bleeding gastrointestinal tumors. Now, why has radiation emerged as an alternative to the conventional intervention? Because sometimes it is not always feasible to go ahead with surgery or endoscopic methods or embolization, because the patient may be unfit for surgery, either due to comorbidities or the performance status, or the tumor is located in such a location that it is not technically possible. And also we know that the architecture of the tumor vessels in cancer is different from that in other cause of bleeding. So the endoscopic methods or embolization may not always be successful. Even if it is successful, patient may present with recurrent bleeding, or sometimes the equipments for endoscopy or the IR team is not available. And in such situations, we can consider for hemostatic radiotherapy. So how does radiation act? Radiation has 2 mechanisms. One is acute and other is late effect. So in acute effect, what happens is radiation damages the intimal cells of the capillaries. And we know once the intima is damaged, it activates the intrinsic pathway of coagulation. It leads to formation of a thrombus. And this thrombus then blocks the lumen of the blood vessel. And in late-term effects, what radiation does, it releases some cytokines which attracts the fibroblasts. These fibroblasts lead to formation of the fibrotic tissue, aiding in the closure of vascular defects. Radiation also kills the tumor cells, so the tumor shrinkage itself may lead to hemostasis. Now, when we are using radiation, what dose and what fractionation should we use? So there is no randomized control trial to determine the ideal dose fractionation. The treatment dose is usually what we decide is based on the patient's prognosis and performance status. And for a better patient compliance, we use the hypofractionated schedules. So what are hypofractionated schedules? We use high dose per fraction and a shorter treatment time. So these are the typical dose schedules that we use, and the most commonly used is 20 gray in 5 fraction, which is delivered over a period of 5 days, or 30 gray in 10 fraction, which is delivered over a period of 2 weeks. And let us see what is the toxicity we can expect. So CTCAE criteria is used to assess the toxicity, and the most common toxicity is nausea, vomiting, and anorexia. And in clinics, mostly we see only grade 1 or grade 2 toxicity because we are not using very high doses, and grade 3 is seen only in 0 to 20% of patients as reported in literature. The response rate with radiotherapy is 50 to 80%. As we know, it is not immediate response that we get with radiation. So the median time it takes is 2 days to act, and the median duration of response is 0.9 to 3.7 months. The overall survival, it is not impacted with the use of radiotherapy, and the studies report a median OS of 2.1 to 5.3 months. So is there any evidence for the use of radiation? So this is a busy slide, I'll simplify it. So we have plenty of studies. The data is still evolving, and most of the data it comes from retrospective series. And we have only 3 prospective observational studies which have been highlighted. As already mentioned, the dose is not standard, and various studies have used various dose fractionation. Now, how to evaluate the response? There are no standard guidelines, but in clinics, what we see is once the radiation has been delivered, does the patient require any further transfusion, or the patient, is there any further fall in hemoglobin after delivering radiotherapy, or does the patient need any salvage procedures like endoscopic procedure post-radiation for at least 30 days from the completion of radiotherapy. And toxicity, as already discussed, is very minimal. So in this patient, since endoscopic methods were not available, we planned for palliative radiotherapy, hemostatic radiotherapy to a dose of 20 gray in 5 fraction. So once we plan a patient, we take a CT scan of the area that has to be treated. And on that CT scan, we mark the area that needs to be treated, and we give it some margins to account for the respiratory motion and for gastric filling. After that, a plan is made in which we decide where the radiation dose will enter. And then we treat the patient on a machine. This is like linear accelerator where the patient is treated. So this patient received hemostatic radiotherapy to a dose of 20 gray in 5 fraction. And he tolerated the treatment well with only grade 1 nausea. And he had response after 3 fractions of RT. The patient was advised further chemotherapy, but he denied. So his further plan was best supportive care. And we can see on follow-up, his hemoglobin remained stable. That's it. Thank you.
Thank you very much, Dr. Anushree, for covering an area which is not very easy to tackle, especially when we have gastric cancers which are fixed to the posterior apparatus and bleeding. So surgery is out. So it becomes extremely difficult because endoscopic control of that bleeding is also extremely challenging. So we have to take the help of this hemostatic radiation therapy, and you've guided excellently to all the surgeons how does it work, what does it do, and what is the outcome. Now, I will invite some questions from the panelists on this talk. Anybody would like to comment? Anybody would like to ask Dr. Anushree any clarifications or questions?
Excellent talk, Dr. Anushree.
Thank you.
I have a question. So we have given hemostatic RT to a patient. So
Yes.
you mentioned the effect lasts for up to 3 months. I mean, roughly,
Yes.
on
Yes.
average. So if the patient bleeds again, so can we repeat or
Yes, we can repeat radiation. In fact, in one of the trials, radiation was repeated within 30 days.
okay.
Yes. So initially they give 20 gray in 5 fraction to the entire stomach. And if the patient had bleeding, they again gave it partial stomach, 15 gray in 3 fractions. So it is possible to re-irradiate.
I will add it that if the patient bleeds again, then
Yes.
no, I
Yes.
mean the third time.
Third time.
Then
So we need to see what is the duration between the first radiation that the patient has received and what doses the patient has received. Because very high doses of radiation may lead to toxicity as well. So we need to take those things into account.
So to the maximum upper limit you can consider, is it not? That's what you're suggesting.
Yes.
Of course, this will be done when, as I said, setup is such that surgery is out. Otherwise, surgery is one of the ways to control the bleeding. Even in a sick patient, ultimately it can be life-saving when the patient is. Usually carcinoma stomachs don't bleed that often. That is
Yes,
fortunate for us. But sometimes when they bleed, control becomes a big challenge. Thank you very much, Dr. Anushri, for covering
sir.
this aspect. And I think as part of it was a little bit covered earlier that what is the role of adjuvant radiotherapy, especially when you have a little suboptimal surgery. Now, before we close, I have a few more questions. In 1 or 2 minutes, I will ask that. One question is directed towards Dr. Kalayarasan. This is from the participants on the who are watching on YouTube. So this question is related to: do you always study vessels on CT preoperatively, and your experience on chyle leak complication when you do the way you describe the dissection for lymphadenectomy with minimally invasive methods, particularly focusing on that, this question is asked. Dr. Kalayarasan.
So, yes, we do definitely look at the vessels on the preoperative imaging. What is relevant in gastric cancer is primarily with respect to the left hepatic artery originating from the left gastric artery. That is something which we always look, and also look at the origin of the left gastric artery. Sometimes you do have a separate origin of the left gastric artery from the aorta directly. So it's always a good idea to have a idea about the anatomy instead of having intraoperative surprises. Regarding the chyle leak, usually the chyle leak is not a major complication except when we are doing at the para-aortic lymph node dissection, or when we are doing the celiac. So the station 9, that's one area where you can get, but often it is a complication after station 16. So the important point to remember is when you do those station 16, because the chyle is primarily the lymphatic channels come from below. So you need to be careful in ligating the lymphatic channels coming from below. So if that is done, then the chyle leak complication can be minimized to a larger extent.
Thank you, Dr. Kalayarasan. One last question. This anybody can answer. Like basically, when you have Sievert's tree cancer, okay, which is classified as proximal gastric cancer, what is the treatment option? I'll ask Dr. Deeksha because she was talking about overall management. Dr. Deeksha, please.
A slight change over there, more role of preoperative chemoradiotherapy.
No,
Then,
surgery I'm asking. Question is what operation?
for type 3 Sievert.
Yeah.
So a total gastrectomy, and proximally we take the lower end of the esophagus as much required to get a negative margin. Also, there is some role of doing maybe sometimes opening the chest and doing a adequate lymphadenectomy via the left lower thorax. But yeah, essentially.
Okay. Actually, I was not talking about mainly about the organ. Okay, so you said total gastrectomy is the primary focus, a little bit going proximity and reconstruction by with the help of jejunum, is it not? That's what.
Yes, sir.
So, look, I mean, the jejunum, rulium jejunum, or do you have a free limb of jejunum? Is there a role for that interposition of free limb in the sense with the vessels? Yeah.
So if it's a total gastrectomy, it's a limb of jejunum. Now there is a upsurge of evidence for a double track reconstruction if a proximal gastrectomy is being done. I personally have not done. I have seen a few cases, but I have not done. So I will not put my bet on that.
Fine. Okay, I think I will close the questions here because we are just 1 minute short. And once again, I take this opportunity to thank Professor Kapoor, all the speakers who have done wonderfully today, Dr. Anushri, Dr. Deeksha, Dr. Sadaf, and Dr. Kalayarasan. And I would like Dr. Kapoor to make some comments. Dr. Kapoor, please, to finish the thing.
Good evening, everyone. Sorry, I could not join actively today, although I kept the Zoom link on. I was just watching. In between, I had to disconnect because we had an important official function at the university, which finished about 15 minutes ago. I would like to thank Dr. Kate for accepting to moderate and conducting this session, and all the speakers and students who have joined the masterclass for the first time. If you want to join the Jaipur surgical tutorial, which is our online education portal, you can find the information about it in one of the previous masterclass videos. In between the sessions, I project slides which show as to how you can join. The contact details of Dr. Anand Nagar, who manages it. So with those words, because we have a convention that we start dot at 7 and finish dot at 9, I would like to thank everyone and have a good night.
Good night. Thank you very much. Thank you.